I'm going to give a bit of an overview of, it's probably a little different tact on the talks that you've had so far. So I'm going to primarily talk a bit about infection control and how like I interact with the board. I tend to use practical examples, so that's what I'm going to talk about. And there's loads of stuff in here, so I'll try and be quick in the 20 minutes that I've got. There's about 50 slides, but I've been quick. Disclosure, just to say thank you to Byron Mario for inviting me to present. So this is where I work. So obviously I work here, so I was like just come from work and then go straight back to work. But we have 4 hospitals across Birmingham, so we pretty much cover the majority of Birmingham apart from the west side. So we've got the Queen Elizabeth, I was taking a picture of it over there. Got Heartlands over there, and Surrey Hall, and then towards the north we've got Good Hope. So they're all quite different hospitals. The QE is like a specialised hospital where we have tertiary referral, we have like major trauma there, or it's the largest single solid organ transplant centre in Europe. So it's a big hospital. When you take them all together, it is pretty much 3,000 beds. What's massive, really, big hospital. So to get onto to tackle your board with some of the issues that we have is tricky because they've got a number of different things to think about. And I think probably it's the language that you use. And infection control, I find, everything we do will have a patient impact. So I find it quite easy to explain some of the things that I need or that I want to our board. And I always try and bring it back to the patients. And then I often think about the terminology I use. And often the pressures that we're seeing at the moment. So, like on the front door, so I always talk about like flow and making gate pins, having patients having a smaller length of stay. That's the type of language I use. If I'm later talks about sepsis today, so I'm going to talk about how to get sepsis onto the board. It's a bit easier for us because, you get massive news stories. And this is from my own hospital. So you can see sepsis last year, CQC reports, and they've obviously got metrics to tackle sepsis. So that's high on our agenda anyway. And you only have to, like I say, look at the most recent CQC report on that. And as I've mentioned, is choosing your vocabulary and words that you use to try get the impact that you want. So I'm going to use a lot of practical examples. So Birmingham, I'm a bit like a kid in a street shop in Birmingham because, not to say this has got loads of infections, but this is some coding data from across the whole country. And the coding data is not great, but it just looks at the amount of infections that we see in our population. And Birmingham is the blue one. And there's just lots of infections that you see within our region. Now there's reasons for that, because we've got like very big pockets of social deprivation over the east side of Birmingham, multi-occupant households. So we do see a lot of infections. We see lots of infections come through our households. If you compare it to like Manchester and Barlston, the trusts, we see a lot of infection. Again, you've got Villa Park over there and you're a Villa fan, so it's quite useful to have this. But this is sort of like the diagrams I use to explain it. And healthcare associated infections, and you will know from the recent point prevalence survey, we see about 10% of healthcare-associated infections. I always use like simple analogies. So Villa Park's got a capacity of 43,000. That means if you extrapolate healthcare-associated infections, it means that 4,300 fans coming out of Villa Park would have an infection. When you look at it, that's lots, isn't it? Some Villa fans, some Blue Bone City fans, but I think you might get digital infections going to Villa Park. But it's just to show you an analogy. And then when you look at that breakdown, there's a big breakdown, and the biggest one is hospital-acquired quiet pneumonia. But this is the ECONI study that was done up in Scotland, and we know that healthcare-associated infections cost a lot of money, up to £1 billion, and bloodstream infections cost a lot, and our length of stay is longer. So like I say, how do I get my interventions across? Well, actually, if you think about all the interventions that we do from an infection control point of view, it reduces down these healthcare-associated infections. That reduces costs, reduces length of stay, and it's better for our patients. So I'm going to go through some practical examples. I'm going to try to link it into AMR. So you probably had a load of talks on AMR today, but this is from our lab report, from our system. This is an organism that you will see carbon coronase producing Ectobacter. And if can you see that on there? Wow. Even some of the newer ones, Cephideric or Cephasmium, Adobactam, How do we treat that? And that's 2 years ago. So we see these regularly now. It's scary. And if that doesn't scare someone with powerful images, it's quite scary when you look at it from an antimicrobial resistance point of view. So CPEs, all depending on your audience, you have to use different messages. So if you go to your medical director, we're quite lucky in the infection field. We've got lots of good peer-reviewed journal articles to go at. But if you look at like clinical infectious diseases and look at, this is some Italian data, the Arico study looking at mortality of CPEs. Look at those CPE mortalities when you get some of these MDMs in the bloodstream infection, 36%, big things. Okay, you might say, well, how relevant is that to the UK? I'll show you some data in a minute from some of our hospitals. Again, next is what I'm talking about when you go to the medical director and he goes, well, okay, you've got healthcare associated infections. So we see 10%. But actually, people who acquire infections and these multi-drug resistant pathogens, this is a study in Lancet Infectious Disease, good journal article, shows that patients who get colonized with bugs, that often precedes infection. And we see that, like our MRSA, and patient who requires MRSA, we would dish out loads of antimicrobials, they go off and get infections. And when you look at our outcome for our CPEs, so we've seen an exponential increase in our CPEs. Okay, this is old data, but what is really worrying is like if you look at the patients who have bloodstream infections and you look at all-cause mortality, our all-cause mortality with these CPEs in the blood is up at 73%. Massive, isn't it, when you look at it? Scary. I know all-cause mortality, you might say it's not CPEs or all-cause mortality, but our all-cause mortality for our patients is in 73%. Okay, it might be like 30. Scary, scary stuff. Hard-hitting messages, know your audience. We do lots of work with the university. I'm not going to go through this, but we do lots of data with the university. University is there, big university, really good. And we do lots of stuff around our CPEs. And we do whole genome sequencing of the plasmids. And we know that our plasmids jump about and transmit about, not the organism transmit about. And these plasmids are really scary. So I'm not going to go through the epidemiology, but what we found is we found a specific KPC that we found in our hospital. And we've only ever found it in our hospital. We've done searches across the world on this KPC is only ever found at UHB. So it's got in somehow from like a importation event. And then what is even more scary, in our liver pathway, this thing has evolved. So can you see those little green dots there, insertion sequences? At some evolutionary point, it's got these insertion sequences in. And that enables it to suck in resistance genes, quinolones, glycosides, scary, and we're just seeing it evolve and evolve. So when you talk about AMR, what's the impact? Well, this thing's in our hospital, it's in the environment. We're selecting it out, big things. Again, we've got other data that we do, and we show that large outbreaks of CPs. This is a large outbreak of a hypervirulent sequence time 395, what's never been seen in the UK with 2 MDMs, and that was across one of our Harlan's wards of 14 patients, 4 deaths. Just showed that to the board, closed down the ward, did our interventions to try and improve it. So what about antimicrobial stewardship? How do we get that over to our board? Hard-hitting messages again. So again, we've got 3,000 inpatients. At any one time, we've got about 1,700 patients on antibiotics. It's amazing, isn't it, when you think about it? Massive amounts. When you look at that, 70% of those are on IV. We know 30% can be switched to oral. And then when we look at our PAT referrals, we know that, again, we can switch to oral, use the instant, don't even need to be on antibiotics. That's a lot. So this is impacting our CPEs, prescribing a lot of antibiotics. Our pharmacist, she's a great pharmacist, great to have her in the team. She's done some lovely work on infographics and data. I'm looking at like AMS. Happily, she'll share this. But when you deliver an IV antibiotic, it takes 22 minutes to give that. An oral is 80 seconds. So if you reduced your IV antibiotics by 30%, you'd free up like a day of nursing time. Massive when you look at it. These are the messages that we use to go to the board. So those are data out there looking at like how precision antimicrobial prescribing. Nice work done by John Atteridge's team down in London, not when he was at Guy's, but it just showed in precision antimicrobial prescribing can reduce down AMS as well, a targeted focus. So these are some of the hard-hitting messages that we tend to use. And as a result of that, we've now got like a fancy dashboard. You might have a dashboard. It looks all complicated, but it shows you where across all our sites, or antibiotics we prescribe. You can't see it up here. This is just a map of meropenem, and you can see the Queen Elizabeth Hospital has it prescribes at least double the amount of meropenem compared to other sites. And there's clearly a reason for that, because the speciality we have, but that's why we see these KPCs and MDMs at the Queen Elizabeth and not so at the other sites. But this is really useful to break down and go and tell our board this is what we're prescribing. And we only got this as a result of telling our board about the AMS and then tackling some of the AMS issues. So how can we tackle CPs as well? The environment, I'm going to a bit more IP here. I told you it's a whistle-stop tour. But those are the hard-hitting messages again, isn't it, when you look at that? So this is our hospital environment. It's dirty, isn't it? And you look at it like fecal matter on there. And I've used this at board. I went to board this year and I said, I need some resources from an environment and cleaning. That's what we're dealing with in our settings. I showed them the science. So this is some lovely data from Brett Mitchell in Australia, and they've done a systematic review, and they show private occupancy. Private bed occupancy is one of the single biggest risk factors for acquiring infections. So if I went into a bed space with Acinetobacter, I shit lots of bugs into the environment. The patient who goes into that room is highly likely to get it. We know that bugs survive for long periods of time in the environment. This is lab data, but you've got clinical data here as well. Again, when I talk about like hard hitting messages and good data. So again, this is Brett Mitchell. This is in Lancet Infectious Diseases, great paper. Really simple study he did. He did an RCT and looked at the impacts of cleaning. So you know the green Flanell wipes that we use. Well, all the study was to do 3 hours of cleaning with those on shared medical equipment per day. That's all he did in a couple of hospitals. And what he found by doing that was a reduction of in infections by 36.5%. Simple messages to go to you. It's easy when you've got these papers, but it's very easy to do that. I'm not going to go through the whole story of this, but basically we've got experience when we have patients repatriated from abroad. It was a big Romanian night club fire. And loads of patients got repatriated back to the UK, and the patient harboured all kinds of different nasty bugs, CPOs, CPs, and everything. And then we knew that we cleaned the room at the time, but we've got lots of experience with CPs, and we thought, fortunately they left that room and didn't put another patient in there and waited for us to come on the next day and say, are we happy with the clean? So we did some sampling. We found loads of different organisms in that. So our required clean at the time wasn't good. So then we had to do a different clean. And it's understanding like the products and things that you're using and having simple messages around that and making it simple for staff and simple for the boards as well. So I know this is a piece of work that we did again looking at wipes, but we made it really tricky for staff. So we used to use 2 wipes. We used to use a detergent wipe and an alcohol wipe. Now, if you don't understand wipes, so the detergent wipe has a surfactant in, and the surfactant is really good at like cleaning. So I don't know if I know Tinra has, but like got brush bite. You do lots of cycling. But if you ever get oil on your I'm not saying you use these, but if you ever get oil in your hands, it's quite difficult to get rid of. So if you use these wipes with surfactant, they're really good at getting the oil. But my point is, they're very good at like cleaning. Well, what we found, staff used to use the alcohol wipe because they preferred the smell. It smelled stronger. But actually, alcohol fixes things to the surface, so it doesn't actually clean. So when we moved over to a wipe that does both, we saw a big reduction down in MRSA, simple things. So I went to the board with that, and then we implemented a one standard wipe. So it was easy things to do that, simple things. We've got issues with CPs at the moment, so we're doing a lot of research into different cleaning agents. So we use a lot of chlorine in our environments. There's some lovely work that's done by Lauren Brown that shows that in a dirty environment, chlorine doesn't work that well, so it gets easily degraded in a dirty environment. And you remember those pictures I showed at the beginning? We have a dirty environment. So we've been looking at other products like peracetic acid, and that doesn't degrade so easily. It works better in biomatter. And so this is a complicated graph, but hopefully you can see we have lots and lots of CPs, the red and the green. So when we implemented peracetic acid, because we know from the sequencing data we have lots of transmission, the CPs. By implementing this new cleaning agent, we've seen a reduction down in CPEs. The one ward where we see a big spike up in CPEs here, they stopped using it then. So yeah, so it's in a roundabout way, a nice study. So, but it's just to show you the simple messages that we use, and to get that kind of funding in. This is the evidence that we go and present. We've got a big thing around. Again, these are hard-hitting patients, aren't they? From an infection control point of view, this is actually from down our drains and down our sinks. This is an IV prep room with a block sink, and this is an IV prep room with an IV tray that you take drugs to patients. That water cultured that both then, and that's an Oxa 48 CPE. So when you're looking at hard-hitting messages, so we were trying to do lots of stuff around like sink care at the moment, and trying to make it a little bit better, a little bit safer. So how do we get that onto people's agenda? How the messages we present? That's quite scary for people. I took it to our medical director, and then I actually took it to one of our board meetings and said, "Oh, that's what we're having an issue with at the moment." And I'm like, okay, what's the relevance of it? So we've done a piece of work looking at like the sink splash zone. So we've just put paper towel on the floor, ran a sink, and you can see like all those dots there. That's how far water splashes. Scary when you look in, when you wash your hands, you see you found a lot more water. But that's actually around our critical care bed space. So we want to do like a water light ITU. So this is how we're going to how we're presenting this. We look what's around your bed space. There's a patient behind there. There's not an actual patient behind there, but that's a patient would be behind there. We've got IV trolley, EPU equipment, bed space. And see what water splashes everywhere. You might say, so what? So what is in that water? Well, actually, so we've gone one step further around the tap, got a little air sampler in there, removed from the room, and let it run, and see what we collected. You can see all the different bacteria in there. But look what we picked up from that splash zone. We picked up Citrobacter, Enterobacter, Pseudomonas, Sphingobacterium. And you remember when I showed you that plasmid at the very beginning in liver? The popped up out of that sink has splashed out of it, peep. So again, when you want to go to like a water light, and start doing that, these are some of the things that we do. There's loads of data out there that shows like using less water, used Hopman, and put like water light care into here, and it showed a reduction. These are gram-negative colonizations in infections, and it showed a reduction down. Hopefully you can see it's all reduced down. Showed a reduction there. And then Giovanni Prachini did some lovely work, again, another meta-analysis, and showed rooms that didn't have sinks had less gram-negative infections. So again, tackling some of these pan-resistant organisms. Again, this is the very final slide, like I said, right on there, right on time, but simple interventions as well. So this is just, do you remember I talked about HAP at the very beginning, that hospital-acquired pneumonia, one of the biggest single pieces of work. So we managed to get a little bit of charities money in, and employed a dental nurse. So you might think, oh, I employed a dental nurse, what did I do? What did she do? She just went round and educated the ward on mouth care matters. So mouth care, make sure our patients clean our teeth. So she did it on a few wards. And what we found on the wards that she did it, so we did a snapshot before, after, over different time periods, we found a reduction down in hospital-acquired pneumonia by 90% by just cleaning some nozzles of that. So that's a big agenda. You've heard of mouth care matters, haven't you, on all of that. So yeah, so that's a big driver of our trust now with mouth care matters. Simple interventions, simple messages. So that's how I try and do it. Very different. I'm very sciencey from my background. So final thoughts. Data. It's how you present. Visuals work very well. Hopefully you can see some of the visuals I've used. Make it simple to understand. Know your audience. It's back to patient safety. We're quite lucky in infection because we can present or install that kind of stuff. I'm a scientist, so I love the science behind some of the things that we do. So I try and explain that, but again, you have to realise your audience. Anyway, I don't do all of that work. It's my team, all my team members is here. So like I'm just the face of all of that. But thank you for listening.